Hello everyone. So today we'll be talking about chronic heart failure, and most of the information here is from NYHA. Here are my references. So first of all, what is heart failure? Heart failure is a syndrome where the heart's ability to maintain circulation is impaired. So as you know, your heart is the organ responsible for pumping the blood, which supplies oxygen and nutrients to every cell in your body, to those cells, and then the blood comes back here and is pumped out again. Um, so what causes this impairment of the ability to maintain circulation? It can be either due to ventricular filling. So this is your heart. The top part here is called the atria, and the bottom part is called the ventricles. Ventricular filling is when the blood is going into the ventricles, as you can see here, and then, or it can be a problem with ventricular ejection, and we will see what kind of problems cause the problem, what kind of conditions cause the problems in filling or ejection later on. So here is the causes of heart failure. It's not not an exhaustive list, but you can think of it in terms of the anatomy of the heart that you can see here. So first, you can have problems with your valves. Valves are the parts where um, it it ensures the blood flows in one way. So problems in your valves when maybe you have regurgitation where the valves don't close properly. So um, when this happens, when your heart contracts, blood will actually flow back into the atria. The blood is supposed to flow from the atria to the ventricles, and then from the ventricles to your vessels. But if there's maybe there's a problem with your heart valve here, then blood will be pumped back into your atria, and hence um, is not very effective, and this can cause heart failure. Other than valves, you can think of the septal defects. So you have two septal defects, two main septal defects. You have atrial septal defects and ventricular septal defects. So this causes the blood in your right and left part of your heart to mix around, and hence this causes reduced efficiency of your blood delivering oxygen to the cells in your body. Or you can think in terms of muscles. So in terms of muscles, it can be either cardiomyopathy caused by drugs or alcohol or other causes, or it can be caused by your heart muscles itself not receiving enough oxygen. So usually your heart muscles are um, there are coronary arteries, the arteries which supply blood to your heart muscles, and the most common cause of heart failure is actually coronary artery disease, where the coronary arteries are narrowed by plaque, or there's a clot blocking the blood from supplying your heart muscles, and this causes your heart muscles to either be ischemic, which is lacking oxygen, or to infarct, which is a heart attack actually. And so other than muscles, you can think in terms of pericardial disease. So usually your heart is not shown here, but around your heart there's usually a pericardium, and it can be too hard. Sometimes there's a condition known as constrictive pericarditis, where your pericardium becomes constricted, and it prevents your heart from expanding properly. It constricts your heart. And other than that, it can be problems with the rhythm. So usually your heart atria pump first, then ventricle pumps. So atria pump the blood into your ventricles, then ventricles pump into the aorta and the veins and all. But sometimes there is a problem with your heart rhythm. So sometimes the atria are undergoing fibrillation, so it doesn't pump properly, or ventricles are undergoing fibrillation, or sometimes your heart is pumping too fast, known as tachycardia, where your heart cannot fill enough and then your blood is pushed out already, or bradycardia, where your heart is pumping too slow, is insufficient for your body cell needs as well. So problems with heart rhythm, you can detect this using an ECG. Or increased demand. So increased demand can be caused by pregnancy, um, or maybe you have obesity. Yeah, obesity is like it has all the ingredients to cause heart failure. So in obesity, don't quote me on this, but around your heart, you have lots of fat in your between your organs. So around your heart, you have all the fat. So it prevents your heart from um, pumping properly as well, and from dilating properly and pumping properly, and it prevents your and also because of obesity, because your body is relatively big compared to your heart, and then you have lots of tissue to perfuse compared to someone who is not obese, so that contributes to increased demand as well. And also obesity, usually people with obesity have um, why they have obesity, because they most of the times because they have too much food, and then it causes their blood sugar. Most people with obesity have higher glucose, higher sugar than normal people, and higher cholesterol content than normal people, and it causes what I mentioned just now, which is the coronary artery disease, where the coronary artery, which supplies blood to your heart muscles, becomes blocked by plaque. Yeah, so the blood sugar damages your blood vessels, and then after it's damaged, your cholesterol, which is circulating in the blood, gets deposited in the blood vessel, and then it causes the plaque formation. So obesity is kind of like you have all the ingredients for your heart to fail. Right. Next, we'll be looking at heart failure classification. So heart failure classifications, you actually got more classifications than this. You have anatomical classifications, where some textbook will talk about left-sided heart failure, right-sided heart failure, or congestive heart failure, where it's a mix of left side plus right side heart failure. But the classifications which are relevant clinically for management's sake are acute heart failure and chronic heart failure, or heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So first we talk about acute heart failure and chronic heart failure. So acute heart failure and chronic heart failure doesn't talk about the severity of your heart failure. It's more of timing of presentation, the onset of presentation. So acute heart failure can be someone who doesn't have heart failure suddenly present with heart failure. You can with kind of suddenly has breathlessness on exertion, walking a few steps. Yeah, this sudden onset, you can call it acute heart failure, or it can be decompensation of somebody who has pre-existing chronic heart failure. So somebody with chronic heart failure suddenly worsen, their symptoms suddenly worsen, and you call that acute heart failure as well. Whereas chronic heart failure is a slow, is a long onset, right? And then heart failure with ejection. Now the classification based on ejection fraction. So you have heart failure with preserved ejection fraction, where the ejection fraction is more than 40%, and reduced ejection fraction, where the ejection fraction is less than 40%. So what is ejection fraction actually? So if you look at the heart cross-sectional view of the heart here. So you can see a normal heart is usually like this, and this is a heart with thickened walls, and this is heart with very thin walls, but it's dilated inside here. So ejection fraction is actually when your heart fills with blood, the blood pool here is 100%, and then when your ventricles contract to push blood into the aorta here, the percentage of blood here which goes out into your aorta is called the ejection fraction. So you can imagine where what situations you can have reduced ejection fraction. So example, your heart is dilated like this and your muscles are not contracting properly. So blood that enters here, 100% of blood is here, and then um, when you contract because the muscles are not working properly, or because this heart is too big, the volume is too big, you not a very small percentage, I mean a relatively smaller percentage of blood goes into your aorta. So if that percentage is less than 40%, so if less than 40% of the blood goes out into your aorta from your ventricles, then it's called heart failure with reduced ejection fraction. And how they actually measure this is by an investigation called the echocardiogram, where they use ultrasonic waves to see the heart muscle movements in real time and see the blood flow in your heart as well. They calculate the blood flow in your heart as well. Right. Other than that, you have the classification based on the severity of heart failure, and this is by the New York Heart Association. So there's an NYHA classification. You have class 1 to class 4. Class 1 is where you have no dyspnea. Dyspnea is shortness of breath, so no dyspnea from ordinary activities. Class 2 is dyspnea during ordinary activities. Class 3 is dyspnea during less than ordinary activities. And class 4 is dyspnea even at rest. Right, and the prognosis of heart failure is usually poor. About 50% of patients die within 5 years of diagnosis. And if hospital admission is required, so let's say they present with acute heart failure with sudden breathlessness, 5 years mortality rate is about 75%. So doesn't look good for the patient. So signs and symptoms of heart failure. So how do you usually present? And these are some of the questions you might want to elicit during history taking as well. So you can think of this in 3 groups. So first you need to understand the circulation here. So I'm not going to go into very much detail, but you can follow the arrow here to see the flow of your blood. These are your lungs, and these are your body cells. Right. So when your heart fails, your body cells don't get enough oxygen and nutrients and everything. So if your brain doesn't get perfused very well, then you have lightheadedness, or you might faint. You have a syncope, which is fainting. And then because the cells aren't getting enough oxygen and nutrients, you get fatigue. If you can ask, you can phrase the question by asking, how are your energy levels? Do you feel that you're getting tired more easily than usual? And also reduce exercise tolerance. Since your cells aren't getting enough oxygen, you can't exert as much as you usually can. So this is one group of symptoms. And then if your heart doesn't pump blood out of if your heart doesn't pump blood out of the heart, heart will actually get the blood will actually get congested. So as if you follow backwards, so if if the heart doesn't get the blood doesn't get pumped out of your left ventricle, it will get congested. There's a lot of blood left here, and then you'll get congested, and blood will be congested in your lungs. And what happens when there's congestion in the lungs? You get breathless. So usually the breathlessness is worse with activity, because if you do activity, your body needs to your heart needs to work harder, but your heart is not able to work harder, and the congestion gets worse. And sometimes it might even happen at rest, like we saw just now in the New York Hearts if heart failure classification. If it's class 4, which is a severe heart failure, you even have breathlessness at rest. And PND stands for paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea. Paroxysmal means on and off, coming and going. Nocturnal means at night. Dyspnea means breathlessness. So typically a person with heart failure, they will wake up in the middle of the night a few times feeling breathless and trying to catch their breath. And this is related to orthopnea. So the pathophysiology of this is that when your body is standing upright, yeah, the blood pools to the lower parts of your body, so your ankles, your abdominal area, and seeps into your tissue, causing ankle swelling and edema, and all that. We'll talk about that later. But when you lie down, the blood that pooled in the lower part of your body returns to your heart, and it returns to your lungs. And this causes, again, congestion in your lungs. So you become breathless when you're lying down. So often people with heart failure, you need to ask them, how many pillows do you need to sleep at night? Or because pillows will kind of elevate them so that the angle is not so flat, and then they can sleep better that way. And then cough with pink frothy sputum. So if you can imagine your lungs are congested with blood, and then the blood seeps because of the pressure, liquid seeps into your alveolar space, and then it comes out, irritates your lungs, and then you cough and it comes out as a pink frothy sputum. And then ankle swelling. So this is the one I talked about just now. This is the third group of symptoms that you can think about. So just now you think in terms of your left heart. Now you think in terms of your right heart. Right side of your heart pumps blood into your lungs, and from your the veins in your body. So if the right side of your heart fails, you will have the congestion of blood. The congestion of blood follows the backflow here, and then because of gravity, most of it will be in your ankles. Your ankles will swell up. You feel your abdomen is bloated, where you have ascites, which is pulling water in your abdomen area, liquid in your abdominal area, and weight gain as well. Weight gain is 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 quite a rapid and sudden weight gain. This weight gain is due to water. So when you have congestion, and then blood pools in your veins and it pools in your tissues, it leaks out of your capillaries and goes into your tissues, and it causes the ankle swelling. And all this water that is in your ankles, is in your abdomen, has weight to it, so you have a rapid weight gain. And this ankle swelling is a pitting edema. So pitting edema means when you press on it, it actually remains depressed for some time. And this goes to show that this swelling is due to some fluid in your tissues. Right. Next, we'll talk about the physical examinations. So just now in history, you need to ask about all those signs and symptoms. You might also need to ask about some risk factors such as diabetes, hypertension, hypercholesterolemia, because the main cause of heart failure is actually ischemic heart disease, and these are all risk factors for it, or any of their families have any heart conditions or any young cardiac death before the age of 40. It might be genetic arrhythmia or something like that. Right. Now going from history to physical examination. So imagine the whole body here. So you start with the hands. So you start with the whole body inspection first. Whole body inspection, you look if he is breathless, he is cyanosed or not. Cyanosed means he appears blue. Okay, I'm not gonna explain each of the medical terms one by one, as from here on it's probably meant for medical practitioners. So I'll be using more jargon from now on. So um, any cyanosis, any breathlessness, um, any look at the whole body for the body habitus. Is he obese or not? And then look at the hands. Look for genuvalations. Look for oscillus nodes. These are signs of infective endocarditis. Look for clubbing. Look for check the capillary refill time. Press on the nail beds and check capillary refill time. Measure the pulse rate, rhythm, and volume. Check for collapsing pulse. Check for radial delay. Check for radial femoral delay. Check the brachial pulses. Check the blood pressure. And then check the JVP. Feel for the carotid pulses. Look at the face. Pull down their lower eyelids. Ask them to look up. Check for anemia. Ask them to open their mouth. Check for cyanosis. Then examine their chest. So in their chest area, you're gonna feel for the apex beat. So check if the heart is enlarged. If the apex beat is detected further away, then it means the heart is enlarged. Then check for thrills, which are palpable murmurs on all the four heart areas, all the four valve areas. So check for trills, then check for heaves, which is the heart beating against the chest wall, and then check for after heaves, you're gonna auscultate the heart. You're gonna auscultate all four areas using the diaphragm and bell of your stethoscope, and then you're gonna check for any stenosis or regurgitation. So oh yeah, one thing to mention is when you're checking for the heart areas, you're listening for normal heart sounds S1 and S2. At the same time, you can feel the pulses to know if there are any murmurs, to know where is the murmur, because as systolic S1 will correspond to your ventricular systole, and then you can feel the blood rushing to either your carotids, or usually you'll feel for the carotid arteries. Right, so you can feel the carotid arteries while listening to the heart sounds, and then you listen for any regurgitation, any murmurs, any regurgitation or stenosis causing murmurs. So in the apex region, you listen using a bell. This is for mitral stenosis. Then listen to the axilla with your diaphragm. Oh, listen with the bell in the apex region, and you can ask them to go into left lateral decubitus position to accentuate this murmur. And then left axilla, you're gonna check your diaphragm for mitral regurgitation. Then you're gonna check the the left second intercostal space, parasternal, and right fourth intercostal space, parasternal, and you ask them to lean forward. You're gonna listen using the diaphragm for aortic regurgitation, and you're gonna ask them to hold their breath, and you're gonna listen for any aortic stenosis, which can be heard in the carotid arteries using your diaphragm. Right, and after that, you're gonna listen to the lungs, because as we said just now, there will be congestion in the lungs, and this can cause pleural effusion. So the most important parts to listen to are the lung bases when the patient is upright, and you're gonna feel if they're sitting a lot, the back of their pelvis for sacral edema, and also feel their legs press and see if it's pitting or not for ankle edema. Right, that concludes the physical examination. Investigations. So usually you do an ECG. So for everybody, you do in primary care, you do an ECG and NT-Pro-BNP. It used to be BNP, and this is a newer version recommended by the NICE guidelines. Might not be available in Malaysia yet. So ECG is look for heart arrhythmias, or any ventricular hypertrophy can be seen in the ECG as well. Any problems with the heart causing the heart failure can be seen from the ECG. And NT-Pro-BNP is diagnostic of heart failure. So we'll see later on, I think, if the NT-Pro-BNP is directly correlated with the patient's prognosis. So very high NT-Pro-BNP is poor prognosis for the patient, and more than 400 is a diagnostic of heart failure. More than 2,000 need to refer urgently within 2 weeks to the cardiologist. Actually, this NT-Pro-BNP stands for N-terminal pro B-type natriuretic peptide. So natriuresis, is excretion of sodium. So this is actually secreted by your heart muscles when your heart muscles are too stretched, or there's too much pressure in your heart. It causes the secretion. It's like a negative feedback mechanism by your body. It causes secretion of this NT-Pro-BNP or any BNP. It causes natriuresis in your kidneys. So when you excrete sodium, water follows and reduces the volume of blood in your whole body, and hence it relieves that stress that your heart is facing. So this is sort of your body's natural response to the heart working too hard. So this is diagnostic of heart failure. Echocardiogram is usually not done in primary care, but is usually done by the specialist, and this is where you can see any valve abnormalities, or you can measure the ejection fraction, so you can the cardiologist can decide on the diagnosis, whether this is heart failure with preserved ejection fraction more than 40%, or heart failure with reduced ejection fraction less than 40%. And then chest x-ray is actually, you do it to rule out other things, because patients usually present with breathlessness. Heart failure is not the only cause of breathlessness. You can be having problems with your lungs as well. So chest x-ray is done quite frequently to exclude other diagnoses. And bloods, full blood count is also most of them is to rule out other things. So full blood count, you're gonna check if there's anemia, check if there's white blood cells are raised, maybe there's a pneumonia. Anemia can cause breathlessness as well. You also check the renal profile. So because your kidneys, if your kidneys are failing, then you have edema as well. LFTs, if your liver fails, you have edema as well because you're not producing as much protein, albumin as normal. Thyroid function tests, hyperthyroid can be causing too much demand, which causes the heart failure, or hypothyroid. Somebody who's hypothyroid might look like somebody with heart failure because of the edema and all. And then HbA1c is a measure of your blood glucose, and fasting lipids is the fats in your blood. So these are actually risk factors. Maybe diabetes, you want to diagnose diabetes, or hypercholesterolemia. These are risk factors for coronary artery disease, which is the most common cause of heart failure. So you're gonna look for that. So these are some pictures. You can see the ECG looks like this. If they had a previous myocardial infarction, which causes their heart muscles to not contract as good as normally can, you can see deep S waves. No, these are not deep S waves, but you can imagine you will see deep S waves if there's previous myocardial infarction. You can see the very tall QRS complexes if there's hypertrophy of the ventricles. You can see axis deviations, which is not in this ECG. So a lot of things. You can see arrhythmias, you can see tachycardia, bradycardia, or any arrhythmias through the ECG as well. There's a rhythm strip. And then the chest x-ray looks like this. So in heart failure, you can see a few typical features. So you have, you can remember it through the mnemonic A, B, C, D, E. So A stands for alveolar edema. Alveolar edema is sometimes called bat wings. A. Let me get the pen. Do I get a pen? So alveolar edema, sometimes they call it bat wings. You see it over here usually because of the congestion of blood in the lungs. B stands for curly B lines. Maybe this is one of them. Maybe this is one of them. It's usually quite difficult to spot. But this is interstitial edema in the lungs. Curly B lines, these are called curly B lines. And then C stands for your cardiac border, so cardiomegaly or cardiomegaly. So usually in a PA erect chest x-ray, you will see, you will measure the heart diameter from the thickest point to the thickest point here, and then you're gonna measure diameter of the lungs, and then if the diameter of the heart is more than half of the diameter of the lungs, it's heart. It's a cardiomegaly. Heart is bigger than it should be. D stands for dilated upper lobe vessels, which I cannot appreciate here, but there are vessels in your lungs, and you can probably see them if they are clear, but I can't really appreciate them. And E stands for pleural effusion. So if you see this here is your cardiophrenic angles. I don't appreciate pleural effusion here, but if there's pleural effusion, this thing will become blurry, it won't be sharp like this. This will be filled with some water. And depending on the severity of the pleural effusion, it can go up to here or anywhere up here. Right. So that's the chest X-ray, and then this is the echocardiogram. I have no experience in reading an echocardiogram, but this ventricle looks like it's pushing against the other side, and then they'll measure. This will be actually done by the cardiologist lah. So they'll measure the ejection fraction as well. I'm not sure if this is the ejection fraction here, 57%. Right. So, so based on the investigations, you can diagnose the patient as having, but usually the diagnosis is done by the specialist. So, in primary care, you measure the NT-Pro-BNP, and if the NT-Pro-BNP is more than 2,000, you have to refer urgently to the cardiologist within 2 weeks. As I said before, NT-Pro-BNP is directly proportional to the prognosis of the patient. So very high NT-Pro-BNP equals to very bad heart failure, and hence need urgent attention from the cardiologist. And then NT-BNP, Pro-BNP of 400 to 2000 is refer urgently within 6 weeks. It's urgent but not as urgent as more than 2000. And then if NT-Pro-BNP is less than 400, then it's not very likely to be heart failure. So usually you refer to the specialist. Yeah, this is a summary table from NICE. It's quite nice. Specialist clinical assessment, including transthoracic echocardiography. So, like I said before, echocardiogram will be done by the cardiologist, and the diagnosis is also done by the cardiologist as well. So if you see NT-proBNP more than 400, you refer within 6 weeks. More than 2,000, refer within 2 weeks to the cardiologist, and they will manage this heart failure for you. So, initial management of heart failure. So these two things you can do first. So stop any drugs that may worsen heart failure. Let's say the patient come to you feeling a bit breathless when he walks about one flight of stairs, or walks about 50 meters, he feels breathless. So you look at the drugs that he or she is taking, and if any of them look like they can cause heart failure, for example, calcium channel blockers, beta blockers, or alcohol, they're taking alcohol, you advise them stop. If they're taking cocaine, stop it. So stop these drugs and refer to cardiologists. And also, if they are feeling too breathless, you can give loop diuretics. So usually the one that's given is furosemide, the commonly given one. So because it provides them temporary symptomatic relief, but loop diuretics doesn't improve mortality and morbidity. It just doesn't improve mortality. Yeah, because it's just symptomatic relief. So you have water congestion in your lungs. It helps you to excrete more fluids from your kidneys, and so you feel less breathless. So management depends on whether heart failure is heart failure with reduced ejection fraction or preserved ejection fraction. If preserved ejection fraction, they can be given low to medium dose of loop diuretics for symptomatic relief. Low to medium dose is maximum dose of 80 milligrams of furosemide or its equivalent. And if it's still not controlled, you gotta refer to the cardiologist. And heart failure reduced ejection fraction, they will benefit from some more other drugs. So loop diuretic, as we said before, is symptomatic relief, and then the first line drugs are ACE inhibitors and beta blockers. So ACE inhibitors and beta blockers, you want to start that on everyone with heart failure reduced ejection fraction. However, you only start one drug at a time, and which drug you start depends on your clinical judgment. So if someone is presenting with breathlessness, signs and symptoms of heart failure, you won't be starting them on beta blockers, because beta blockers might worsen their symptoms of heart failure. You will be starting on ACE inhibitors first. If that patient is presenting with angina, where he feels chest pain or regurgitation sometimes, and then relief by rest, you're gonna start them on beta blockers first, because that will help their angina. So depending on their presentation, eventually you're gonna want to start them on both of the drugs, and then if these two doesn't work, then you can add an MRA. MRA stands for mineralocorticoid receptor antagonist, which one example of this is spironolactone. If you remember your physiology, all these ACE inhibitors and MRA act on the RAS pathway, renin-angiotensin aldosterone path system, right? So the end effect is it blocks aldosterone effect on your kidneys, and that aldosterone actually functions to reabsorb sodium in your kidneys, and when sodium reabsorbed, water follows. So if you block aldosterone, you block the sodium reabsorption, you block the reabsorption of water, more water comes out from your kidneys when more water gets excreted, right? One thing to note here is ACE inhibitors a lot of times, not because of racist issue, but because of genetics. It might not be suitable for Afro-Caribbean patients, or some people will react to it by having a dry cough, and it might be very uncomfortable, and then you're gonna switch to ARB, angiotensin 2 receptor blockers, so the sartans. And I think I've covered all these beta blockers. The rule is to start low and go slow. I'm not sure. All right, here there's another table from NICE for treatment. So let's look. Chronic heart failure diagnosed by the specialist. So diagnosis by the specialist, he comes back to you, the primary care physician, for management, for continuation of management probably. So with preserved ejection fraction, you don't really give all these drugs, so that's why I say this classification actually matters for management. So if the ejection fraction is more than 40%, you don't need ACE inhibitors, beta blockers, or mineralocorticoid receptor antagonists. So you manage comorbidities, offer personalized exercise-based cardiac rehab program unless condition is unstable. And if heart failure reduces ejection fraction, you order ACE inhibitor and beta blockers. These are the first line drugs, as I mentioned just now, and mineralocorticoid receptor antagonists if symptoms continue. And as I say just now, consider angiotensin receptor blocker, the sartans, if intolerant of ACE inhibitor. If all this doesn't work, this is what you can give in primary care. If all this doesn't work, you gotta seek specialist advice, refer them to a specialist or seek their advice. If ACE and ARB not suitable for them, you can consider they can be started on hydralazine and nitrate. These are direct vasodilators. One of them dilate your arteries, and one of them dilates your veins. Dilating arteries reduces afterload, and dilating veins reduces preload of your heart. But these all will be decided by specialists, so I'm not going to go into a lot of detail. You can look at them yourself. So remember, first line, ACE inhibitors, beta blockers. If it doesn't work, MRAs. If ACE is not suitable, use ARBs. And these are examples. So beta blockers, you can see not all beta blockers are licensed for heart failure. These are the ones licensed for heart failure: bisoprolol, carvedilol, and nebivolol. These are the ones for heart failure. Diuretics, these are your loop diuretics. Other than furosemide, you have bumetanide and torsemide. ACE inhibitors, you got captopril, enalapril, fosinopril, lisinopril, perindopril, quinapril, ramipril. So all of them you start low, start at the low dose, and then okay, yeah, here's your angiotensin 2 receptor antagonist, your sartans, candesartan, losartan, valsartan. Start at a lower dose whenever you start all these medications, and start one drug at a time, and increase whenever you start either the ACE inhibitors or angiotensin 2 receptor blockers or the diuretics. Before you start, you need to check their blood pressure. Check their blood pressure and check their renal function as a baseline. So, and then after starting their dose, you're gonna see them in 1 to 2 weeks to check their renal function again. Because one of the famous questions that are asked in Mosler's in New Med is when ACE inhibitors, when you have bilateral renal artery stenosis, ACE inhibitors will cause the deterioration in your kidney function. So when you check the kidney function again, if it increases, if serum creatinine increases by more than 30%, then you need to either stop the ACE inhibitors or you need to find out what's wrong. You have to find, maybe you're going to do an ultrasound to see if he has bilateral renal artery stenosis, or you're going to reduce the dose if it's not suitable for them. Right. So all these three drugs, ACE inhibitors, angiotensin 2 receptor antagonists, and diuretics, check their renal function, check their blood pressure whenever you start, whenever you increase the dose. Yeah, check 1 to 2 weeks after you change the dose or after you start. Right. I don't think there's anything else to add here. So talk about acute management, short-term management. We talked about giving the beta blockers and the ACE inhibitors as first line, and MRAs if that is not enough. Long-term management, you have non-pharmacological and pharmacological. Non-pharmacological management includes educating the patients on the symptoms of heart failure. So tell them, heart failure, when your heart fails, you have these symptoms. You have breathlessness, you have ankle swelling, you feel abdominal bloating, you might experience sudden weight gains, actually due to fluids, and advise them to report them. Don't hide them during the follow-up. And if these symptoms become really bad or becomes worse, you need to seek medical attention. And reduce salt intake and maintain fluid balance. So studies have showed that reducing salt intake reduces your blood pressure. Also, if you think about it, all your drugs here, ACE inhibitors, angiotensin 2 receptor blockers, they work by inhibiting your aldosterone, which functions to reabsorb salt from in your kidneys. But if you take too much salt, then kind of defeats the purpose. So you need to reduce your salt intake and maintain fluid balance. So maintain fluid balance, a lot of people on heart failure, you're on fluid restriction. So for example, maybe the cardiologist has told them to take only a maximum of 1.5 liters to 2 liters of fluids a day, depending on the severity of their heart failure and their symptoms. This is just an example. So because if you drink too much water, you will cause your breathlessness because there's too much volume in your blood. And then at the same time, you don't want to drink too little water to the point that you get dehydrated. So you need to maintain fluid balance. One useful method is maybe you can ask them to weigh themselves every day at the same time every day. So for example, after they have went to pass their urine, but before they put on their clothes, you ask them to weigh at the same time every day and then see if there's any sudden increase in weight. Let's say an increase in 3 kg or 2 kg in 3 days. Probably something, since probably you are drinking too much fluids and it's causing swelling in your leg, ankles, and causing your weight gain and also your abdominal bloating. So monitoring your weight frequently may help you decide on your fluid balance maintenance. So you need to teach them about sick day rules. So sick day rules, let's say a patient with heart failure has diarrhea and vomiting. So what are you going to do? Because diarrhea and vomiting is lots of fluids. You're losing lots of fluids. So you're going to ask them to maintain their fluids, and then you're going to ask them to stop certain medications. So some medications that you need to ask them to stop are, if they are taking ACE, ask them to stop ACE for 1 to 2 days, or diuretics also you need to stop for 1 to 2 days. If they're taking this, stop for 1 to 2 days. And maintain a fluid intake. And if it doesn't get better, it's longer than 2 days, then you might want to see the doctor. Yeah, because you need to check your electrolytes. You need to check your electrolytes and your hydration and all that. And the usual advice, stop smoking and alcohol, because smoking constricts your arteries. So I've mentioned this time and time again that the coronary artery disease is the leading cause of heart failure. So smoking causes coronary artery spasm and it reduces the blood flow to your heart muscles, and because of this your heart muscles can undergo ischemia, infarction, and you can have heart failure. And if you already have heart failure, this is definitely not good for you. And alcohol can cause alcoholic cardiomyopathy. If your heart failure is due to alcoholic cardiomyopathy, it's best you stop alcohol completely. Otherwise, you have some leeway of 14 units maximum in a week, and don't binge. This is normal advice. And advice on losing weight. As I said in the beginning of the presentation, obesity has all the ingredients for heart failure. So if your BMI is more than 30, advise on losing weight. So advise them on some low intensity exercise, as I advise them on diet. Or low intensity exercise. Why low intensity? So because and exercise is only if they are stable. You don't want them to go into acute heart failure because of exercise. So if they are stable, low intensity exercise such as walking, because probably their heart cannot support moderate to intense exercise. And driving and pregnancy. So driving, you have you need to refer to the VLA for the rules. But if I'm not mistaken, briefly, two different types of license, Group A and Group B, Group 1 and Group 2, or Group A and Group B. So Group 1 is the personal one, Group B is the heavy goods vehicles one. Group 1 if your heart failure symptoms doesn't distract you from driving, you can continue driving and you don't have to report to DVLA. But it's their responsibility to report to DVLA if their symptoms does distract them from driving. And group B, you cannot drive anymore. You gotta report to DVLA and your license will be taken away, but you can reapply after that. And pregnancy. So a lot of the heart failure medications, ACE inhibitors, angiotensin receptor blockers, they are teratogenic. So they are best avoided in the first trimester of pregnancy and contraindicated in the second and third trimesters of pregnancy, because this can cause your baby to be abnormal. So, and the other issue is the heart cannot support. When you have pregnancy, you need to supply blood to two organisms. You need to supply to your own body cells, and also you need to supply them to your baby. So you have increased demand when the heart is failing. Your heart can't keep up with this increased demand, and it's quite dangerous for the patient who wants to get pregnant. So if you need to advise them on get the pregnancy, that they shouldn't get pregnant, and about contraception. But if they really want to get pregnant, you have to advise them to continue their contraception and refer them to a cardiologist and an obstetrician. So they will advise them on the management. Right, and discussion on advanced care planning. As I said before, the prognosis for heart failure is poor. More than about 50% mortality in 5 years since diagnosis, and if hospital admission, about 75% mortality in 5 years. So advanced care planning, you look at the severity of the heart failure. If it's severe, you probably want to discuss about this. It includes them researching about end-of-life care, what kinds of end-of-life treatments are available, and see which treatments they want and which treatments they might not want. There are advanced care directives will tackle that, and also their lasting power of attorney. Let's say they cannot make decisions for themselves anymore, who is going to make decisions for them? Yeah, so this is what advanced care planning is about. And then long-term management in terms of pharmacological, you're gonna consider antiplatelet and statin therapy. So because coronary artery disease is the leading cause of heart failure, statin therapy will lower the cholesterol in your blood, so it reduces the chance of plaques forming in your coronary arteries, and then because of these plaques, usually there will be blood clots forming near these plaques and causing total blockage. So to prevent the blood clots from forming, you give antiplatelets. And then also annual influenza vaccine and once only pneumococcal vaccine, because these conditions can worsen somebody with chronic heart failure and cause them to present with acute heart failure. Their heart rate is already not good, and if they get infections, it's definitely not good for them. So refer them for vaccination. And I think that's all I have. Thank you.